Friends, again we'll see the important topic on the liver pathology, the tumors of liver, mainly the benign tumors and the malignant tumors. What do you think? Which tumor is more common? Most common liver tumor, primary or metastatic? Yes, it is the metastatic tumors are very common in the liver as well as even in the lung. So they are the two important sites where the malignancies will go and deposit. Right? Metastatic tumors, especially to the liver, can occur from colon, especially from the pancreas or from the from the breast tissue or from the bones. Anywhere in the body, the tumors can metastasize to the liver, including even lymphomas, leukemias, melanomas. So any tumor can get deposited in the liver. So liver is the most important site where metastatic tumors are seen. So let us have a look on the primary tumors of the liver as such. What are benign tumors of the liver and what are the malignant tumors? Most important malignant tumor is the hepatocellular carcinoma. So let us see what are the causes for hepatocellular carcinomas. And remember, this is also known as hepatoma, but that word would have been not so good. Actually, it sounds like as if you are dealing with a benign tumor, hepatoma. But still, in certain books, especially in old edition, you will see that hepatoma word is there. So don't confuse. Hepatoma is nothing but hepatocellular carcinoma. The word HCC, hepatocellular carcinoma, would have been better term that you have to use. So benign tumors of the liver are adenomas and hemangiomas, mainly cavernous hemangiomas. Malignant tumors, the pediatric tumor is the hepatoblastoma. Angiosarcoma is the one which is occupational related, chemical mediated. And hepatocellular carcinoma, this is the one what we are going to read in detail, study in detail. Cholangiocarcinoma is actually the tumor of the bile duct epithelium. Liver will contains the bile ducts and they can give rise to the malignant tumor, very rare tumor, cholangiocarcinoma. Cavernous hemangiomas, most of the time they are deep-seated, usually seen in the internal organs like liver, spleen, and so they show cavernous spaces lined by endothelial cells and they contains plenty of blood in the lumen. So this is classical appearance of the cavernous hemangiomas. So what is the problem with the cavernous hemangiomas? They can mimic like a tumor masses, especially cystic tumor masses. Whenever the ultrasound, the radiologist will do the ultrasound, and if at all you put a needle accidentally, it can cause a massive hemorrhage. So that's cavernous hemangioma. Should be careful, and if you confirm that it is a cavernous hemangioma, just excision of that particular lesion could be totally curative. So they are not much problematic, but the ultrasound guided some manipulation like biopsies can become problematic. So liver cell adenomas are said to be very common with women who are taking OCPs, oral contraceptive pills. That is one of the adverse effect of these oral contraceptive pills, but they are known to regress once the woman stops the oral contraceptive pills. They regresses after the discontinuation. But again, radiologically they can be mistaken for hepatocellular carcinomas. They have a chance of getting ruptured, so they can become big and enough, and they can rupture into the liver, and they can even cause the severe intraperitoneal hemorrhage. So that is the problem with these liver cell adenomas. So they can be mistaken for HCC or even for any other lesion, but you have to do the biopsy. Here the biopsy will be useful for differentiating adenoma from hepatocellular carcinomas. Rarely they can harbor, very rare, but most of the time hepatocellular carcinoma arises de novo. Adenoma turning into hepatocellular carcinoma is very rare phenomena as such. Remember, the most common pediatric childhood tumor again is the hepatoblastoma. So it is a blastoma containing the germ cell tumors, so affects the young children. It is fatal if it is not treated within few years of span, and it contains two components, epithelial component and the mesenchymal component, sometimes mixed epithelial and the mesenchymal component. Epithelial component is mainly consisting of the polygonal fetal appearing hepatoblast, and they appear small to medium size. They are all embryonal cells. It can show mesenchymal differentiation in the form of the osteoid cartilage formation, sometimes even the striated muscles, and there can be variable amount of proportion of mixture of the epithelial component and the mesenchymal component. Most of the time we see the mixed form of the hepatoblastoma containing predominantly epithelial and good amount of mesenchymal, but the proportion can vary from one case to the other case. Angiosarcoma, very peculiar malignant tumor of the liver, mainly related to the occupational hazards, like exposure to the vinyl chloride is most important, the one that we will ask commonly in the MCQs. Exposure to which of the following carcinogenic agent will cause the angiosarcoma? So remember, it is the vinyl chloride. Not only that, arsenic, thorotrust, all those things can cause the angiosarcomas. It is again known for widespread metastasis, even it can go to the lungs and to the bones. Again, very aggressive tumor, kills within a year. So that indicates aggressiveness of this tumor. So unless you detect them early, treat them early, it carries very, very bad prognosis. So with that, let us have a look on the primary carcinomas of the liver. Hepatocellular carcinoma. So this is hepatocytic in origin. The old name was hepatoma. The one more rare tumor that can occur in the liver is the cholangiocarcinoma. Remember, they are bile duct epithelial cell origin. So cholangiocarcinoma, don't think it is something else or unknown entity. It is the tumor of the liver arising from the bile duct epithelium. You know, we have bile duct, bile can look like bile duct, so that bile duct epithelium can give rise to this rare tumor, cholangiocarcinoma. That's a rare tumor. Most importantly, we have to know about the hepatocellular carcinoma, HCC. So hepatocellular carcinoma, very common in the North and South American population and even European population, and even in China, it's again HCC is very, very common. 2 to 4 cases per year per 1 lakh population. And high incidence areas, especially these are the one, Southeast China, Korea, Taiwan, and they will have around 150 cases per year per 1 lakh population. So different country will have a different incidence of these hepatocellular carcinomas. And males, it is very, very commonly seen in the males. US blacks will predominate, very high incidence in the males. So it is all related to the indirectly to the incidence of the hepatocellular hepatitis B virus infection, because that is said to be one of the important risk factor for the hepatocellular carcinomas. High carrier state, almost around 200 increased risk of development of the hepatocellular carcinomas. Cirrhosis may be there or may not be there in most of the cases. So seen around 20 to 40 years of age. So what is the etiological factors in the low risk areas? In the low risk areas, around 80 to 90% of the cases will have associated cirrhosis. So remember one important thing, that cirrhosis can progress to hepatocellular carcinomas. So cirrhosis could be due to so many underlying causes, right? We have seen the causes for the cirrhosis in the previous presentation. It could be due to the alcohol abuse, it could be due to the viral hepatitis, mainly hepatitis B, C, D can cause the cirrhosis, and even B and C are more important in causing the hepatocellular carcinoma, and even super infection with the D also imposes the increased risk. Not only that, alpha-1 antitrypsin deficiency, Wilson's disease, they are the rare causes for cirrhosis, and even the variety of drugs can cause the cirrhosis as such. It could be cryptogenic, where cause is not known in some of the cases. So we have one more peculiar Indian childhood cirrhosis, very, very rare cause of the cirrhosis that can rarely end up as a hepatocellular carcinomas. Most important is the, again, chronic alcoholism is the important cause, and hepatitis C infection is also important cause. It is all at the actually molecular genetic level. It's not much clearly known. Probably there is a genetic mutation of the WNT and beta-catenin pathway, so that causes the altered triggers to the signal to the hepatocytes. They will continuously proliferate and they can cause the carcinomas of the liver. So, but it's all variety of genes, especially it's the P53 gene again that is get mutated in these hepatocellular carcinomas. So increased cell turnover will be there in patients with hepatitis B and C infections. In cirrhotic patients, more and more mutations will get accumulated. It is hepatitis B virus infection which is known to get integrated into the the host cell genome. So it's a viral integration. So there is a formation of so-called as hepatitis B X protein. X because we don't know exactly what is the nature of this particular protein. It is said to inhibit, it causes the, viral gets integrated with the host cell genome that inhibits the P53. So P53 is get inactivated, it will get mutated. So transcriptional factors are get activated. Growth promoting genes are get activated. So probably this oncoprotein is the one which is responsible for the onset of hepatocellular carcinomas. Not only that, we have aflatoxins. Remember, aflatoxins are very mycotoxins. They are actually aspergillus, the group of the fungal. They are usually seen in the ill-formed foodstuffs like groundnuts and even onions. So they will be excess amount of this black pigmented fungus, that is aflatoxin, that is said to be hepatotoxic. So ill-formed groundnuts, they can be a source of aflatoxins, and variety of food substances can develop this aflatoxin. So stored food for a long time, especially in the humid areas, so it can cause the accumulation of this mycotoxin, which is hepatotoxic. So this also can cause mutations in the P53 genes, and even proto-oncogenes will get activated. They can turn into oncogenes, and that can secrete the oncoproteins. Very commonly in the sub-Saharan African countries, China, this kind of onset, that aflatoxin causing the hepatocellular carcinomas, is common in these countries. So remember, cirrhosis can progress to hepatocellular carcinomas. Cirrhosis can be either hepatitis C infection or chronic alcoholism, hemochromatosis, and even hereditary tyrosinemia. So there are rare causes. So hemochromatosis again can cause the cirrhosis, and all of them can turn into hepatocellular carcinomas. What we see in gross examination is either unifocal or multifocal, or sometimes diffusely infiltrative. Unifocal in the sense the tumor lesion will be only single lesion, and such a lesion can mimic so many entities. So it is the ultrasound guided or CT guided biopsy. Sometimes even aspiration also will come to help. So it's a biopsy which will prove the diagnosis. So if it is unifocal, you have to hit that particular area. Multifocal, and sometimes it could be diffusely infiltrative. So hepatocellular carcinoma varies a lot on the gross examination of the specimen. So two hepatocellular carcinomas can be totally different. Especially problematic area is the multifocal hepatocellular carcinomas. When it is multifocal, see, multiple nodules are seen in the liver parenchyma. That is very, very difficult to differentiate from adenocarcinoma deposits. Say a patient is having breast carcinoma that is showing multiple deposits in the liver. So then it is really challenging for pathologists and even for the radiologist to differentiate, is it a multifocal hepatocellular carcinoma or metastatic adenocarcinoma from some other areas. So if the history is there, past history of say patient is known case of breast carcinoma, then you can easily tell. But if there is no past history and patient can have a occult neoplasms in the body and suddenly manifesting with multiple secondaries in the liver, then it is a diagnostic challenge for radiologist and even for pathologist. It is very, very difficult to differentiate unless we do the immunohistochemistry markers. We cannot predict what could be the primary origin. So that is multifocal hepatocellular carcinomas, really diagnostic challenge. So have this look of this case. This is unifocal hepatocellular carcinoma. So this needs a ultrasound guided biopsy to hit this particular lesion, and once the tumor is there in the slide, you can predict. So it appears, it shows the features like this. Most of the time it shows this particular trabecular arrangement of cells, and it shows marked anaplasia features of these epithelial cells. So these are all hepatocytes as such, but they are highly pleomorphic, very prominent nucleoli is there. Normally also prominent nucleoli will be there, but here it's very prominent, very striking macronucleoli, sometimes macroeosinophilic nucleoli. So sometimes bizarre appearing tumor giant cells are here. So all these features are suggest that it is highly undifferentiated or anaplastic tumor. So sometimes high mitotic activity is seen. So these features are suggest that it is a hepatocellular carcinoma. So to diagrammatically represent the same, you see that hepatocytes will show variation in the size and shape. There is a pleomorphism. There are mitotic figures, bimitotic, tripolar mitotic figures, abnormal mitotic figures. Most important again, tumor giant cells are there, very, very bizarre appearing cells, and prominent eosinophilic nucleoli. So remember, there are few tumors with prominent eosinophilic nucleoli. So make a list of them, right? So hepatocellular carcinoma, malignant melanoma, most important. Again, there is a macronucleoli, eosinophilic. Then Hodgkin's lymphoma, where again we see oval appearance or a mirror image appearance with a prominent eosinophilic macronucleoli with a perinucleolar clear halo. Then we have even seminoma and dysgerminoma. Again, we see prominent macronucleoli, eosinophilic nucleoli. So make a list of these all the tumors where you see prominent eosinophilic macronucleoli. So clinical features of hepatocellular carcinomas. Sometimes it could be seldom characteristic of anything like that. Sometimes patient can have a marked background of cirrhosis and chronic hepatitis may be there. Patient can come with abdominal pain of upper abdominal pain and malaise fatigue. Most of the time they will have a associated weight loss, and mass can be palpated sometimes if the tumor is located near the surface. Invariably, patient will have some amount of jaundice, fever can be there, bleeding may be there or may not be there, it all depends. It all depends on how much liver is get damaged. So what you have to do? You have to do the laboratory investigations. Most important tumor marker is the alpha fetoprotein. It is raised in around 60 to 75% of the cases. They will have increased levels of the alpha fetoproteins. So remember, my friends, the tumor markers are useful for the diagnosis, but more than the diagnosis, they are useful for the follow-up of a patient who is having carcinomas. Follow-up in the sense, once you resect the tumor markers, serum levels should go down. So you monitor the patient, they will be at a basic level. Again, if they are rising in their levels, serum levels, it indicates that there may be a recurrence of a tumor, or there may be resurgence of the tumor, or metastatic tumor may be now growing. So they are actually useful for the predicting the prognosis of the disease as such. But problem with these tumor markers, so false positive rates. See here, false positive alpha protein levels are seen in even yolk sac tumors. That means yolk sac tumor also produces the alpha fetoprotein. Cirrhosis patients, massive liver cell necrosis itself can cause the raised alpha fetoprotein levels. Even in normal pregnancy, there can be increased levels of the alpha fetoproteins. Fetal distress can also cause, fetal defects like a spina bifida can also cause the raised levels of the serum alpha fetoprotein levels. So that's why it's a good tumor marker, but false positive rates are also there that you have to keep it in your mind. Small lesions you cannot detect sometimes, that's a problem. So death occurs within 10 months. The patient will have a severe cachexia. Patient can have a severe bleeding that can even cause the death. And sometimes patient even can go for the hepatic coma. And rupture of a tumor into the peritoneal cavity can cause intraperitoneal hemorrhage, sometimes massive enough to cause the death. So there is a very peculiar type of hepatocellular carcinoma that you have to remember. They will ask in the exams, in the MCQs. Fibrolamellar type of the hepatocellular carcinoma is very commonly seen in the females. As the name itself indicates, fibrolamellar, there is excessive deposition of the fibrocollagenous tissue. And this is the one which is having best prognosis. So hepatocellular carcinoma with the best prognosis is the fibrolamellar type, more common in the females. Affects young adults of 20 to 40 years of age. There is no association either with the cirrhosis or with the hepatitis B virus infection, and it will carry better prognosis as compared to the other common hepatocellular carcinomas. So 5-year survival rate is as high as around 60%. One of the rare tumor of the bile duct epithelium is the cholangiocarcinoma. May be related to the thoracost and other liver fluke infection that can also cause the cholangiocarcinomas. So liver fluke, you have to remember, that it's infection, parasitic infection, but can cause the cholangiocarcinomas. So they are very aggressive tumor. So death occurs within 6 months. So that indicates their aggressive behavior. And microscopically, they also resemble like any adenocarcinoma for that matter. And most of the time, they are poorly differentiated adenocarcinoma. So it's a ductal epithelial carcinoma. So it's a kind of adenocarcinoma only, and it is having very, very bad prognosis, cholangiocarcinoma of the liver. So that's about the primary tumors of the liver. Remember, metastatic tumors are the ones which are very, very common in the liver. Metastasis can be from various organs in the body. Read more about these liver pathology and liver tumors. Thank you.